You know that feeling, that specific kind of panic when you're standing in front of a fire hydrant that's just blasted open.
Oh, yeah.
You're trying to get a sip of water, but you're just getting hit with 1,000 gallons a minute.
That is the perfect metaphor for the first year of medical school. It really is.
It's just so much.
It's not just the volume, it's the speed. You've got anatomy, pathology, pharmacology, all coming at you at once. And the trick isn't just absorbing it, it's keeping it all straight.
Right. And that's really where our deep dive starts today. We're not just talking about how to, survive the flood. We're talking about how to actually swim in it.
Okay.
We're looking at first aid cases for the USMLE Step 1, 3rd edition. Now, for anyone who hasn't seen this is not a textbook you just, read before bed, is it?
Definitely not. No.
No.
If you try to read it like a novel, you'll either fall asleep or worse, you won't retain a thing. This book is a simulator.
A simulator. I like that.
It is. It's designed to bridge that gap between I memorized a fact and I know how to treat this patient. It uses 363 specific cases to force you into what we call active recall.
Okay, active recall is a term we hear all the time, but let's break down what that actually means in practice.
Yeah.
Because, looking at a list of symptoms is one thing.
Yeah.
But having a patient actually walk in and say, "Doc, my stomach hurts," that's a whole different ballgame.
Precisely. Passive learning is just reading the list. Active recall is when the book gives you a clinical vignette, a short story about a patient, and then it just stops.
Right.
It forces you to come up with the diagnosis yourself before you flip the page. It's training your brain to retrieve information, which is exactly what happens on the exam and on the wards.
So today, let's do that. Let's simulate the experience. We've got cases from biochemistry all the way to neurology, and we're going to play medical detective. Let's start with the one subject that gives everyone nightmares.
Biochemistry.
Biochemistry.
It's the one everyone wants to just forget, but it's the foundation of everything. The book starts with general principles, and there's a case in there on fructose metabolism that is just perfect for understanding how this all works.
Okay, so set the scene for us. We're not just talking about, eating an apple here.
Well, in a way we are. The case is about a child who starts having some really serious problems, vomiting, low blood sugar, right after being weaned from breast milk and starting on, say, fruit juice. And the question is just, why?
And the first thought for a parent would be allergy, right? But this is metabolic.
It's a traffic jam in the liver. The book contrasts two different conditions, essential fructosuria and hereditary fructose intolerance. And this distinction is so important because one is basically harmless and the other can be fatal.
Wait. How can one be harmless and the other deadly if they're both about breaking down sugar from fruit?
That's the beautiful and terrifying part of biochemistry. In essential fructosuria, the problem is with the very first enzyme, fructokinase. If you don't have it, the fructose just kind of floats around, can't really get into the cells, and you just pee it out.
So no harm, no foul.
Exactly, benign condition. But the second one, hereditary fructose intolerance, that's where the trap is. Here, the deficiency is in a different enzyme called aldolase B.
Okay.
So the fructose has already been processed one step. It's inside the liver cell as something called fructose 1-phosphate. It's trapped. And because aldolase B is missing, it has nowhere to go.
It's just stuck there.
It's worse than stuck. It accumulates. And here's the key. That fructose 1-phosphate traps all the inorganic phosphate in the cell. Your liver needs that phosphate to make energy ATP and to release its stored sugar.
So by trapping the phosphate, you're basically freezing the liver's bank account.
That's a perfect analogy. The liver has all these resources, but it can't access them. So it can't release glucose. The kid's blood sugar plummets, and the liver cells start to die, all from one missing enzyme.
That's incredible. It really shows that it's not just about what you're breaking down, but where the assembly line breaks. Now, shifting gears from the molecular to the moral, the book also hits behavioral science, which feels like a huge pivot.
It is, but on the board exam, you'll go from an enzyme question to an ethics question in a split second. You have to be ready. Case 5 in the book is a classic. Confidentiality and its exceptions.
This is the kind of stuff you see in TV shows. A patient tells you something dangerous, and you have to decide, do I keep this secret or do I call someone?
And in real life, it's an agonizing choice. But for the exam and in the book, there are very clear rules. The case might involve a patient making a credible threat to a specific person, for example. The takeaway is that confidentiality is critical, unless public safety is at immediate risk.
So you're not just learning the biology, you're learning the legal framework around being a doctor.
Exactly. You're learning to be a physician, not just a scientist.
Speaking of being a physician, let's get into microbiology. This is where I really feel like the job becomes like Sherlock Holmes. You have a suspect, the bug, and a bunch of clues.
Microbiology is pure detective work. You're just matching a story to a microscopic culprit.
Hmm.
There's a fantastic case on cryptococcal meningitis that shows this perfectly.
So who's the patient in this kind of scenario?
Typically, it's someone who is immunocompromised, a patient with AIDS or maybe on immunosuppressant drugs. They come in with a headache, fever, stiff neck, classic meningitis signs. But the big clue is in the lab work.
And the book points to the India ink stain. I've always thought this was so visually striking. Can you describe what we're actually looking at?
It is really striking. So most stains, they dye the cell itself. India ink is what we call a negative stain. It dyes the background black. But the thing about Cryptococcus is that it has this massive, thick polysaccharide capsule.
Okay.
The ink can't get through it. So when you look under the microscope, you see this dark black background and then these bright, clear halos where the yeast cells are.
Like looking at stars against the night sky.
Exactly like that. And that halo is the telltale sign. If you see budding yeast with a halo in the spinal fluid, you've found your culprit. It's a visual you'll never forget.
There's another detective story in here that I think is even more practical for most doctors. It's about pneumonia, but with a strange twist.
Legionnaire's disease. This is a classic board exam question. You have a patient with pneumonia cough, fever, chest x-ray, looks bad. But then, almost as an afterthought, the case mentions they also have diarrhea.
And most people would just think, oh, well, maybe they have a stomach bug too.
Right, but here's the thing. In the world of the USMLE, there are no coincidences. The book gives you a hard and fast rule. Pneumonia plus diarrhea equals Legionella until proven otherwise.
Why is that? Why would a lung bug cause GI issues?
Because Legionella is a systemic disease. It's this gram-negative rod you get from contaminated water, sources think air conditioning units, cruise ships. It hits the lungs for sure, but it also causes GI upset and, weirdly, very low sodium levels in the blood. It's that whole constellation of symptoms that just screams Legionella.
I love that rule. No coincidences.
Oh.
Let's move on to pharmacology. This is the part that usually makes people's eyes glaze over because it can feel like just memorizing a phone book of side effects.
It can be so dry, but again, the case-based method saves it. Instead of a list of side effects, the book gives you a patient who's suffering from one. There's a great case in the GI section on acute pancreatitis that ties it all together.
Okay, so the patient is a 50-year-old man. He's HIV positive, and he's in agony. The pain is in his upper abdomen, and it's radiating to his back.
Radiating to the back, that's the buzzword. That points you straight to the pancreas. Now, to get the drug connection, you first have to understand what pancreatitis even is.
It's inflammation, right?
Yeah.
But it's a lot more violent than that.
Yeah. Much more. The pancreas is basically a bag of digestive enzymes, like grenades. Normally, the pins don't get pulled until those enzymes are safely in the intestine. In pancreatitis, the pins get pulled inside the pancreas itself.
So the organ starts digesting itself.
Autodigestion, that's why the pain is so horrific. So the question becomes, what pulled the pin? And this is where the book gives us that famous mnemonic, get smashed, to run through all the possible causes.
I feel like every med student knows this one by heart. Let's go through it, but I want to focus on the weird ones.
Okay, so G is gallstones, E is ethanol or alcohol. Those are the big two. T for trauma, S for steroids, M for mumps, A for autoimmune disease. And then we get to the second S.
The scorpion.
Yes, S is for scorpion stings.
Okay, I have to stop you. Scorpions, how often is a doctor in, say, New York City going to see pancreatitis from a scorpion sting?
Almost never. But it's in the book and it's on the exam for a reason. The venom contains a toxin that basically hyperstimulates the pancreas. It forces it to overproduce enzymes until it just bursts. It teaches you about the mechanism of overstimulation.
So it's an edge case that proves a larger point.
Exactly. Then you have H for hyperlipidemia or hypercalcemia. And finally, D.
D is for drugs, which brings us back to our patient.
Right. Our patient was HIV positive, and the case mentions he's taking a drug called didanosine. It's an older HIV medication that is notorious for causing pancreatitis. So the mnemonic forces you to think past the obvious, like alcohol, and consider the iatrogenic cause, the one caused by his treatment.
That's a great example of how you have to look at the medication list as a list of potential suspects. Okay, let's get physical. Part 4, musculoskeletal and anatomy.
Yeah, now we're switching from the internal chemistry to the mechanical structures. The book uses a classic knee injury case to teach anatomy, which is so much better than just staring at a diagram.
So we have a 19-year-old athlete. She plants her foot, pivots, hears a loud pop, and her knee just gives out.
That pop, is so specific. If you hear pop plus immediate swelling and instability, you're thinking ACL tear, anterior cruciate ligament. But the book makes you understand why the knee gives out.
It's like a seatbelt inside the knee, right?
That's a great way to think about it. The ACL connects the back of the thigh bone to the front of the shin bone. Its job is to stop the shin bone from sliding too far forward.
So when it snaps, the seatbelt's cut. The shin just slides forward.
Correct. That's why we do the anterior drawer test. You literally pull the shin forward, and if it moves too much, the ACL is gone. The book uses that to explain the function. It's anatomy in action.
There's another anatomy case that always terrified me a little. The recurrent laryngeal nerve.
Oh, yeah. This is every neck surgeon's worst nightmare. The book shows the path this nerve takes. It goes down into the chest, loops under the aorta on the left, and then comes all the way back up to the voice box.
It takes the scenic route.
A very dangerous scenic route, because it runs right next to the thyroid gland. So the case is usually a patient who just had thyroid surgery, and now they wake up and their voice is extremely hoarse.
Because the surgeon accidentally nicked the nerve.
Exactly. It's a perfect example of how knowing the anatomy is directly tied to surgical risk. You have to know the map.
Let's move to what I always call the math of medicine, part 5. Renal physiology. Acid-based stuff. This is where people's eyes can glaze over, but the book makes it systematic with the Anion gap.
The Anion gap sounds like something from advanced calculus, but really it's just simple accounting.
Okay, break it down for us. No whiteboard.
Think of your blood as a party that needs to stay electrically neutral. You have your positive ions, mostly sodium, and your negative ions that we measure, like chloride and bicarbonate. They should roughly balance out.
But they don't. There's always a little gap.
Right. Because we don't measure all the negative ions, things like proteins and phosphates. So there's this normal small gap of about 8 to 12.
But what if the gap is, like, 25?
Taking up space. And we have to figure out who it is.
And just like with pancreatitis, there's a mnemonic for the guest list of suspects. Mud-D piles.
Yep. This is your lineup for high anion gap metabolic acidosis. M for methanol. U for uremia, which is kidney failure. D for diabetic ketoacidosis. P for paraldehyde. I for iron or INH. L for lactic acidosis. E for ethylene glycol.
Antifreeze.
Antifreeze, right. And S for salicylates, like an aspirin overdose.
It's amazing. You have antifreeze and diabetes in the same list.
Yeah.
Two wildly different things, but they both show up as the same mathematical problem in the blood work.
And that's the power of it. You don't have to guess. If the gap is high, you just run through mud piles. It turns chaos into a checklist.
Okay, let's wrap up with part 6, neurology. This section covers some of the most complex diagnoses like multiple sclerosis or MS.
MS is so tricky because the symptoms can be anything: numbness, vision loss, weakness. So the book, again, focuses on the lab work. We're looking at the spinal fluid.
For crypto, we looked for the halo. What are we looking for in MS?
We're looking for something called oligoclonal bands. These are specific bands of antibodies, IgG, that show up. And the book says they're present in 85 to 95% of patients with MS.
So if you see the bands, it's MS case closed.
Ah, not so fast. And this is where the book is really smart. It explicitly warns you. These bands are sensitive, but they are not specific.
Okay, explain that difference, because that is a critical point.
It's huge. Sensitive means if you have MS, you're very likely to have the bands.
Got it.
But specific would mean that only MS causes the bands, and that's just false. You can see oligoclonal bands in Lyme disease, in lupus, even in syphilis.
So if you just look at the lab result and ignore the patient's story, you could diagnose MS when they actually have an infection like Lyme disease.
Exactly. The book teaches you that a lab test is a clue, not a conclusion. You have to treat the whole patient, not just a piece of paper.
We have covered so much ground today. From liver enzymes to knee ligaments to the math of kidney failure. It really shows how this book works as a total review.
It's a tour of the human body gone wrong. And the real value isn't just memorizing the mnemonics, it's seeing the connections. Understanding that a pop in a knee is a mechanical failure, or a gap in the blood work points to a hidden poison.
Before we sign off, we have to make sure everyone listening was actually paying attention. We're going to do a little active recall of our own.
That's right. So I'm going to pose a quick question based on our discussion.
Sure.
A patient comes in with that severe stomach pain radiating to the back. You're thinking pancreatitis. You start running through, it gets smashed in your head. I want you to tell me two things.
Right.
1, what does the venomous S stand for? And 2, What does the D stand for? The iatrogenic cause from our HIV patient's case.
Okay, I'll give you a second. Think about the desert.
Yeah.
Think about the pharmacy.
Ready?
All right, the S is for scorpion sting. Remember that whole overstimulation mechanism. And the D.
The D is for drugs, specifically in that case, the antiretroviral didanosine.
If you got that, you are well on your way.
And remember, the goal isn't to rely on these mnemonics forever. Mud piles get smashed. They're just the training wheels. The real goal is to build that knowledge so deeply that when you see a patient, you don't have to spell out a word in your head. You just know.
That's the transition from student to doctor. It's instinct built on a foundation of knowledge. So as you go about your day, try to spot the patterns. Thanks for listening and keep diving deep.
See you next time.